I'm Professor Miles Prince, Haematologist at Epworth Healthcare, and this is the third time I've had the opportunity to talk to you about updates of COVID-19. And welcome to those of us who joined us before. If you're out there, please give us a thumbs up and let me know that you're involved, and also be free to pass on any messages, questions along the way, because I can read them off my screen and address them. So what I thought I'd talk to you about this week in the 10 minutes is firstly just a few updates and then some questions that have come. So probably the biggest issue is around social distancing. As I've mentioned in the last couple of weeks, we're in for the long haul. The next few weeks is about flattening the curve. Beyond that, the virus is still going to be in the community. We know that. Hopefully less than initially anticipated, but it's still going to be out there, and patients with blood cancers do need to look after themselves. And the issue is that this virus is droplet spread. What we understand about the virus is that it replicates up in the head and neck, particularly up in the throat, and so droplet spread is very, very important, very critical to how this virus is spread, and therefore close contact is bad. And so even if patients are completely, patients can have this virus and have no symptoms, but if they're kissing and cuddling, they can spread the virus. So social distancing is critical, and that is making a difference, and it will make a difference, and it's got to continue to make a difference while this virus is with us in the community over the next few months. Ultimately, we hope we'll get a vaccine which will protect us, but in the meantime, social distancing is critical. A lot of people talk about, well, how do I interact with my family? The answer is simple. It is social distancing. And I think the weaknesses potential is people who are coming in and out of the social environment, and so you need to be aware of what your brothers, sisters, children, etc. are doing, and making sure that they're as diligent about social distancing as you are, because it makes the difference. So stay at home if you can stay at home. That leads us really to the issue of telehealth. There's been lots of questions about what is telehealth. Well, ultimately, as a doctor, a lot of the discussion, a lot of what we glean from the patient, we can get from talking. Yes, some patients we do need to examine, we do need to check before to make sure that their disease is under control. But a lot of the time it can be simply getting information about symptoms. So a lot of doctors are using just a straight telephone conversation, and I would say that works a lot of the time. And it can be very simple, very quick, and doctors, it's just a matter of, if you haven't been told already, ringing up your doctor's rooms and saying, can I do a telehealth? Would it be appropriate? You'll hear back, and the doctor will ring in and make a phone call usually. Bearing in mind, it's just like a clinic, we could be running late, so you need to block out a certain period of time to take that. There's also via the computer, through the various web-based interactions, and that's really up to the doctor's surgery. If the doctor has to see you, then that's clearly why web-based computer system works well. Remember, you're not alone. You're not the only person that's going through this. We now are getting a feel for patients at risk, how to run the clinics, how to move people in and out of the hospital quickly. We're learning every week, so don't be afraid to ask questions. The other big thing that's changed in the last week is that we've got much better COVID testing, and the turnaround times are quicker. So better availability, better processing, quicker. And what that's going to mean is that if a person thinks that they're at risk, we're going to be able to find an answer within 24 or 48 hours. So that will make a difference in terms of social isolation. So you're worried you've got it, go and get tested. You'll have the answer within a couple of days, and you'll be able to move on, know whether you've got a virus or not. So specifically around questions that are out there, please ask questions if you are wondering, or something I say raises an issue. So people are asking, do we become immune? How will we know? The short answer is we don't have all of that data yet. It's a learning curve. Watch this space. In other words, if a person has got and had the COVID-19, they will become immune, but how do we test it? What's the reliability of the testing? Still, we don't know. Watch this space. The flu shot. The flu shot is a very safe thing to do. So to avoid confusion, we're coming into winter. The flu is another type of virus. It's the influenza virus. It's different to the COVID virus, but there are similarities. If you're protected from COVID, you're not protected from the flu. Hopefully with social isolation at the moment, the flu season will be less. Nonetheless, you need to be vaccinated. There are flu vaccines out there now for different age groups, but there is a new quadrivalent vaccine that's coming and becoming more available. So there will be some patients that need it now, and you need to contact your doctor, speak to your haematologist, others that can wait for a few weeks till the flu vaccine gets into the GP. One of the other questions that frequently comes up is we're hearing in the news that cancer patients are at risk. Well, it's fair to say that the types of patients that are at biggest risk we still are unclear about. The patients in China that died that were cancer patients were predominantly lung cancer patients, and those patients were predominantly smokers, also had underlying lung disease. This may have made them more susceptible or unable to recover from it. So there are other factors, but it makes sense that with immune suppressive therapies that we should be modifying treatments, keeping people away from hospital. So a lot of the treatment changes that we're suggesting for patients are about keeping people away from hospitals, limiting their blood tests, limiting their visits. How they're going to change specific therapies is really up to you and your doctor. Suffice to say, there are some clear indications which I mentioned last week about avoiding transplant, and in fact we and members of the Myeloma Scientific Advisory Group to Myeloma Australia approached the PBAC, the Pharmaceutical Benefits Advisory Committee, and they have approved for the use of extra Velcade to be used in patients that have just been diagnosed with myeloma, who normally would only get 4 months of treatment and then move to transplant. For patients where we're delaying transplant, the government have approved an extra few months of Velcade to allow us to delay transplant. That's an example of how treatments are changing. And so the key at the moment is speak to your doctor. As a haematology community, if you're in the midst of treatment, there may be some adjustments. I've had a question about patients with chronic myeloid leukemia who have had some of the drugs used in that, and some of them do affect the lungs and the breathing. Now, that per se does not increase the risks of COVID, but any sort of underlying lung disease can inhibit or limit recovery. So it's really important that those people make sure they follow the social distancing and social isolation issues. Speak to your doctor about the breathing issues. Make sure that that's all treated and optimized, but it doesn't per se increase the risk. So talking about risks, age is the most important. I try and tell people and try and score them their risk out of 10, but ultimately what I've found over the weeks is that the biggest issue has been around age. So we have to be careful. Even if you're feeling fit and healthy and you're older, you need to be careful and follow the instructions about staying at home, social isolation, speaking to your doctor. Last message. I had a patient, my first patient with COVID-19 a couple of weeks ago. Monday he rang me, his brother had come back, his son had come back from overseas, and he was given, his son unfortunately had COVID, he got COVID. He felt well on the Monday, he was at home, he was social isolating, he had a minimal cough. By Saturday evening he was unwell, he had to go to hospital, he didn't get intensive care. But what happened was it got worse. Don't assume that you're 5 days in, you're just going to get better. It's not like a cold where, oh, I'll hang it out here. You need to let your doctor know. You need to let people aware, because this can be tricky. You can be well and you can get sick 5 or 6 days down the track quite quickly. So last question is about ibrutinib and CLL. Speak to your doctor. There's some guidelines coming out now, but in short, don't stop your treatment. If you get COVID, there is a recommendation at the moment to discontinue your ibrutinib if you are positive. So the scenario may well be symptoms, tested, positive, stop ibrutinib. But in the middle, you're going to talk to your doctor. And last question from Susie. Nice to have you there, Susie, listening in. Thanks, Eve, from the College of Pathologists, who's also presenting this information. For patients with immune thrombocytopenia, really steroids at higher dose potentially can increase your risks. It's not a huge difference, but it depends on the dose of the steroids, how long, and if you're on other immune suppressants. If you're not on any treatment at the current time, there is minimal effect. So I'm going to leave you there. Again, I hope you enjoyed the update. I hope you found it useful. Please send us in some messages. And last of all, if you're stressed, keep calm. Of interest, Snowdome have got Fifth Direction, where is a free meditation. We've had a couple of our Snowdome supporters involved. It's free. Go to the Snowdome website and keep calm and keep well. Thanks very much.